Okay, thank you for inviting me here, and I shall speak with the treating psychotic patient with agonist opioid therapy and atypical antipsychotic. In a group of my sampling, I work in drug addiction unit in Bologna, in the center of Italy. This is an observational and spontaneous study in a patient, and the aims of this study is to evaluate the efficacy of olanzapine in patient maintaining methadone, to explore time course variation of craving and weight at baseline and every 2 months for the first 6 months, and then every 6 months until the end of the study, 30 months, to compare symptoms severity between patients on buprenorphine and patients on methadone. Patients were enrolled from the East Outpatient Addiction Unit in Bologna. All signed a written form consent. 32 received methadone and 13 buprenorphine. In base exclusion and inclusion criteria, we choose 36 patients and we divided into 3 treatment subgroups. 12 patients take olanzapine add-on to maintenance treatment with methadone. 12 patients in maintenance treatment with methadone, and 12 patients in maintenance treatment with buprenorphine. You can see in this slide the inclusion criteria. Patient received treatment at East Outpatient Addiction Unit in Bologna from the 1st and 15 March 2006. Patient treated with methadone or buprenorphine. Patient taking oral contraceptives. Exclusion criteria: diagnosis of type 1 or 2 diabetes, obesity, pregnancy, and breastfeeding. All the patients have a clinical assessment, a baseline and follow-up session from T0 and every 2 months from T0 to 6 months, and then every 6 months to 30 months. We administered the scale to all patients. Minnesota Multiphasic Personality Inventory 2 to identify personality structure. The structure clinical interview for the SM4-AX2 disorder, sheet 2. Background and mania melancholy scale to cover severity of manic and depressive symptoms respectively. And the VAS, Visuologic Analogic Scale, to quantify craving for drugs. Is a very easy method to quantify in this model the intensity of craving for drug. The score range from 0 to 100. During the observational period, urinary metabolites of heroin, cocaine, and cannabinoid were randomly dosed. You can see in this slide the gender of my sample, the age subgroups, the civil status, and the occupation. You can see the substance abuse of all 3 groups. You can see the similar use of opioid in all 3 subgroups. The therapy of the group of olanzapine: 75% take 10 milligram of olanzapine, 10% take 15 milligram, and 15 patients take 20 milligram. The dosage of methadone was from 70 milligram to 100 milligram daily. The dose of buprenorphine was from 60 milligram to 22 milligram daily. The result of urine sample have tested negative for heroin, cocaine, cannabinoids, metabolite time T3 6 months. No metabolic complication have been found among the 3 subgroups. The result of MAPI-2, a significant difference was found among the 3 subgroups in baseline, supplementary, and content scale. The number of patients who achieved score greater than 65, cutoff value adopted to identify pathologic trait. The sheet 2 results: the frequency of personality disorder at baseline was 72%. The most common personality disorder were included in cluster B, in particular antisocial personality disorder and borderline personality disorder, as you can see in this slide. The statistic at T6 at the end of study significantly reduced background and mania and melancholy score in all subgroups, in particular in the first who take olanzapine and methadone. As you can see in this slide, the important degrees of the score of melancholy from baseline to 6 months, and for mania scale for baseline and 6 months. And you can see the total score in comparison for the first group in red with other two subgroups who take methadone and buprenorphine, an important decrease with significant P less than 0.001. The same for mania scale, and in the follow-up period, total and partial Berg, Raffens, mania, and melancholy score did not significantly change during the follow-up period from 6 months to 30 months, even if the curve display a downward trend. As you can see in this slide, you can see an important decrease in the first period, then slowly decrease. But this is an important goal for the patient. They improve the quality of life. They don't have thus you can see after, thus for the drug use. After 6 months, no difference was found among the 3 subgroups. Even the olanzapine and methadone can achieve better results and more quickly and keep them for a long period. You can see in this slide the comparison from the first group in purple for other subgroup. You can see the important decrease in the first period, and then slowly and the stabilize of the score of melancholy scale, and the same for mania scale. We choose the weight gain. No significant difference was detected in all patients at baseline and the end of the study. You can see in the first period an important increase of the weight, then a little decrease, a stabilization from 6 months to 30 months of the weight. I think it's important to monitor the patient and to do to the patient an important educational training of FAD. The ANOVA between group demonstrated no difference at T0 and T6. Also, the ANOVA within group show no difference within each group at the first of the period. You can see in this slide the trend of weight in all 3 subgroups. You can see in purple the first subgroup who take methadone and olanzapine in comparison with other 2 subgroups. You know the methadone can improve the weight of a patient, the same of olanzapine. The association is a problem for patient. The statistic, none of the 3 treatment induced a significant weight gain both after 6 months. At this time session, we observed better results in the treatment of mania and melancholia, even a small peak of weight gain at the end of the study. At this time session, we consider a background and mania melancholy score corresponding to maintenance phase. We observed the maximum weight in the first group 6 kg, in the second group 7 kg, in the third group 4 kg. VAS score was significantly lower both at 6 and 30 months. P is significantly less than 0.001 when compared to baseline condition. You can see the total sample, and as baseline we observe no significant difference among the 3 subgroups. The ANOVA within group shows the difference within each group. The ANOVA between group demonstrates significant higher VAS score between olanzapine methadone and other 2 subgroups with P less than 0.001. This is very important. You can see in purple the first subgroup, the decrease, an important decrease in comparison for other 2 subgroups. 3 patients dropped out from the study immediately before 30-month session as they stopped olanzapine for weight gain, 5 kg for 1 patient and 3 kg for 2 patients. Another limit of the study is we don't have a group to comparison buprenorphine and buprenorphine with olanzapine. We don't try. A considerable proportion of patients saw that they are short bipolar psychiatric syndrome and cluster B personality disorder. Recurrent substance abuse behavior may depend on low self-esteem, severe impulsivity, and novelty-seeking attitude. Patients don't tolerate physical and psychological pain and to wait. They prefer action to soothe and they more fluctuate. The liability of mood is very severe. They react to small daily problems with anger. Patients characterized by mood instability, guilt, and paranoid ideation. Even if patients don't meet all diagnostic criteria of the DSM-4, they still need care. The purpose of this study has been to offer a therapeutic strategy for anxiety, paranoid ideation, mood lability, anger, and uncontrolled behavior reaction. We choose olanzapine for its antipsychotic and mood stabilizing property. In fact, we observe improvement in background and melancholy score for depression and in the only patient with manic symptoms. The background and melancholy and mania score can be interpreted as an alteration between the self and the body and between the self and the world. Improving in this score means improving quality of life and addictive behavior. We can say that olanzapine stabilizes instability. Also, as likely by literature, olanzapine has an anti-craving effect, useful in the secondary prevention addictive behavior. Good compliance to antipsychotic treatment. We don't observe metabolic complication. Buprenorphine was prescribed to patients with lower symptom severity and younger. Take-home message: at 30, all urine tests were negative. Constant caregiving and clinical monitoring have improved patient motivation to treatment. This message is very important in Italy because the number of patients who contact addiction unit is increased while time and resources available are limited. The association of methadone to olanzapine, even in presence of their short psychiatric symptoms, improve treatment adherence in substance abuse. I thank my colleague and thank you for your attention.
Thank you very much.